Hello, Dr. Lewis. My name is Donald Walker. My clinical site is Weeks Wellness Service Incorporation, and it's located in Chicago. I'm going to be doing my oral presentation on the patient that I saw on October 5th. And this is a patient, a 58-year-old African-American female, date of birth 05/25/1965, who came to the clinic. Accompanying was a reliable historian. Chief complaint, quote unquote, I'm here because I've been experiencing pain and swelling in my right lower leg in the last 4 days. HPI, a 58-year-old African-American female came into the clinic complaining of discomfort, redness, and edema in her right leg. The symptoms, according to her, have continued for the past 4 days. The patient claimed that she first noticed the symptom a few weeks ago and that they gradually got worse over time until starting to grow worse for 4 days ago. She reported that she always experiences leg pain, which is eased by sitting down or resting the leg. She continued by saying that standing and moving her leg sometimes aggravated the discomfort, which made it challenging for her to walk. The patient admitted having a pain in the right calf and was rated 4/10 with an intermittent aching sensation. She denied injuring her leg. PMH, hypertension, hyperlipidemia, allergies, no allergies. Surgery, she denied any surgical history. Medications, patient currently take lisinopril 10 milligram PO, QD, hydrochlorothiazide 25 mg PO QD, and simvastatin 20 mg PO QID. Immunization, she's up to date. No history of psych. Social history, she denies tobacco, cigarettes, or marijuana use. She denies any use of drugs, cocaine, heroin, anything like that. She admits to drink alcohol maybe once a while. Occupation, she works at the post office. Marital status, she's married and currently and she lives with her husband. Diet, she reported not eating vegetables or fruits often. She works out at the gym occasionally. Family history, father, hyperlipidemia, mother, hypertension, hyperlipidemia. She has two brothers, brother 1, hyperlipidemia, brother 2, hypertension. She has 2 kids. Past medical history, no past medical history. Review of the system, everything pretty much unremarkable except the extremity. The patient experiences right calf soreness, minor edema, and right lower leg redness, no ulcer. Objective vital sign, temp 98.2, heart rate 88, respiratory 18, and blood pressure 135/88, SpO2 97% room here. Pain is 4, weight 175 pounds, height 68 inches, BMI 26.6. General, she seems to be in pain aside from the complaint of right calf pain. Extremity, the right lower leg is somewhat swollen and red. The right calf, tenderness and a palpable cord running parallel to a vein in the popliteal region. Right foot dorsiflexion was accompanied by pain, no ulcer. Any other thing were unremarkable. So the tests I considered for this patient were pretty much D-dimer and ultrasound of the proximal leg vein, and I also used the assessment of clinical probability of DVT using a well scoring system where the number of symptoms that the patient presented will determine the consideration for the diagnosis and the type of treatments to utilize either outpatient and inpatient. And since D-dimer could not be done at the clinic, so I consider this patient to be a high probability criteria for diagnosis. So my plan was to send the patient to ER, which I did. Assessment, patient was considered a high probability of criteria for diagnosis, and because of the things that I discovered from her. So the differential diagnosis, deep vein thrombosis, ICD code 10, I82.401, cellulitis, ICD code LO3.90, and also post-thrombotic syndrome, which I rule out because patient has never had any history of DVT. I also rule out cellulitis despite the fact that she has some pain and swelling, but because of other things that she presented, which does not conform with the diagnosis of cellulitis, so I cannot rule that out too. And the rupture basic cyst was other differential diagnosis, which will be ruled out when she gets to the ER to find out through the ultrasound or CT scan. So like I said, the plan for this patient was to send her to ER because of things, the assessment that I carried out. And asking about the question, the reason why I chose to refer the patient to ER, I collaborated with the patient and the family, even though she didn't want to go, which was the reason why she came to the clinic. But I told her that the chance of her not going will increase the risk of her getting PE. I don't want the DVT to transfer to her lungs for her to have pulmonary embolism. And she agreed with me, and that's why I sent her there. This case was interesting because I think I did a lot of work with her, even though it was challenging because of the fact that it could lead to misdiagnosis, because I was thinking about cellulitis when I saw that. And it was interesting and meaningful because everything that I did, I partnered with my preceptor and he agreed with me to send the patient to ED. So instead of waiting for all the D-dimer, ultrasound, why can't we just send the patient to ED, which was what I did. And so he agreed with my preceptor, agreed with me about that. The rationale for coming to the formulation of the diagnosis was because the total criteria points count for the patient was 3 or over 3, so which is why she was a high probability for diagnosis of DVT. The detection of palpable cord running parallel to the vein in the popliteal region and the dorsiflexion, which is more like Oman sign, was also an indication that the patient has a DVT. So, so I told the patient to go to ER, which would be a better fit for her because of she required the higher level of care. And I know pretty much the IV heparin drip will be started if everything was confirmed that she has a DVT. And within 1 week, patient, will be discharged, and then I can follow up on that. So thank you so much, Dr. Luis, and I appreciate your criticism. Thank you.